Oh, so how you been, Murray? You've been traveling?
Yeah, I was in Incheon last week as a visiting professor, and then I will be in Beijing for the rest of the summer.
Oh, wow, it's a long time. A fellowship, huh?
Yes, it's a short-term fellowship, that one from Eospine.
Oh, okay, it's not with Ben in Shanghai,
No, 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 it's in Beijing. Uh,
Beijing.
Bingsu is in Shanghai and mostly does vascular, whereas my area is neurotrauma and spine.
Oh, you with who you with in in Beijing?
Would be at the Peking Third Hospital.
Must be
Third
huge,
University
right?
Hospital. So it's a huge center. They do like 13,000 operation a year.
Wow.
Um, yeah, it's a it's
So
a it's a huge center.
you get some
Mostly,
hands-on experience, probably,
yes,
right?
yes, 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 yes. Mostly they are orthopedic spine surgeons. But there are also a lot of neurosurgeons. They cover the full breadth of the spine curriculum, from craniocervical junction to the sacral, lumbosacral and pelvic structures. And mostly I'm going to look for robotic surgery, endoscopic and exoscopic
Oh,
surgery.
wow, exciting.
Yeah.
Those guys seem to be the best.
Look, you know, the famous pivot to Asia that they described almost 10, 15 years ago. I think this is really happening.
Yeah,
The best surgeons that I'm seeing are actually from India, China. We had many discussions about that in the past. And I think it's a matter of having the volumes, and certainly they have.
I would love to have access to their archive of videos,
Mhm.
but I'll never get that. With AI, would tear it up.
But look, even in Incheon, the past 2 weeks, I have seen a lot of interesting cases, bypasses, endoscopic spine. You know, they have a lot of OPLL, and therefore
Yeah.
we did anterior, posterior approaches for that. So it was a very good experience. I also got the chance to see the all the landmarks for the Incheon landing in 1950 when the U.S. Marines reconquered Incheon and then Seoul.
Yeah.
So it was very nice experience from that point of view.
Have you been to China before?
Yes, I've been to Shanghai and Suzhou, but it was like 12 years ago. It has all changed now.
Do you like it there?
Yeah, uh,
Yeah.
different culture, um, different culture, and I'm sure that it will be changed a lot compared to what I remember 10 years back.
Yeah. Probably more open.
I hope so.
Yeah, probably more. But I've never had a problem, just stick to medicine, stick to neurosurgery.
Mm.
Don't get involved in anything else.
And John, all this goes on YouTube afterwards, correct?
Yes, yes. It'll be forever on YouTube on the neurosurgical channel. If you just Google it, you'll find it. Well, this one obviously is not edited, so once we edit it, we'll put it up. We'll cut the part intro. Oh, and we'll take the Zoom version, which, once I go 10, 9, 8, 7, 6, boom, that's when we start recording.
Yep.
Right there. Just like Hollywood. Although Clint Eastwood, when he directs a film, he doesn't go 10, 9, 8, 7, 6. He says, let's go ahead. Go ahead. Luigi's here. Hello, Luigi.
Hello, how are you?
John
Good
Bennett
morning.
from Neurosurgical
How are you?
TV.
Ciao.
Ciao.
And you know Mario.
Yes, it's a friend of mine. Yes.
We've been in touch since 2005. It's already a lot of time,
Yeah.
21 years. So Luigi, you spent some time in New York at Cornell,
The 3 months.
3 months.
No, 4 months.
Mm.
Yes, it was 2010. Yeah.
After the neurosurgical training.
Antonio Bernardo.
Mm. So it was before Anna
Excuse
Vista, right?
excuse me, Mario, have you got a hold of Victor?
No, after.
Okay.
Victor knows,
Victor
Mario?
knows and is going to connect, and also Phil.
Yeah.
And they both told me that they are happy with the time, so I think they will be connecting fairly soon. I'm going to
Okay.
text them.
Okay. You don't have to start exactly on time.
Um,
A lot of times
so,
people come at the last
provided
minute.
Victor is happy, I suggest, because he told me that he need to leave around after half an hour, so I'll have him giving the talk,
Okay, so he'll
short
be first.
Q&A, and then he can leave. Then we have
Okay.
Phil,
Okay.
and then we have last Luigi. So I'll ask questions at the end of each talk.
Good day, Phil. I'm John Bennett from Neurosurgical TV.
Yeah.
Hi, everyone.
Hello, Phil. How are you doing, my dear?
Good. How are you?
All good.
How's
all good.
everyone? Hi, Luigi.
Here's
Hi.
Victor.
Hey,
Hello,
Phil.
John.
Hi. Hi, John.
John Nasua.
Everyone, hi. It's a pleasure being here. Hi, Mario.
Hey, man.
Victor, I haven't seen you in about 8 years.
Yeah, that's right. Nice to see
I
you
don't know
again.
if you remember, but we did some Romanian
Of course I do.
webinars
Yeah,
a
I
while
remember.
back.
Of course I do.
Where are you now, Victor?
Still in Rotterdam, as always.
Okay, we'll start in 2 minutes. People will come in as we go along.
So,
Hi,
John, I
Victor.
will introduce the webinar, and then I will let you introduce Victor. Is that okay?
Okay.
You want to introduce the webinar?
Yeah, I'll
Whatever you
introduce.
want. I can just go to you. We don't have to go to me.
No, that's fine. So when you
Yeah, let
come-
me just introduce the conference, then you can take over
Perfect. Okay.
and you run it.
Yeah.
Perfect.
Okay,
And then John, when I'm done with the brief intro, because it's a vascular presentation, you introduce Professor Volovic, okay?
Okay, that's fair enough.
who do I introduce?
No, not you, the other.
Okay. Okay, 1 minute.
Perfect.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. Today we have the honor of hosting the Global Neurosurgery Grand Rounds. led by Mario Ganal from Oxford University Neurotrauma. And I'm going to basically let him run the show. Good day, Mario.
Thank you, John, and thank you, everyone. We continue with our Oxford Global Neurosurgery Initiative webinars. Today we have a wonderful panel of speakers, really representing the best of neurosurgery from many parts of the world, particularly North America and Europe. I will let my co-faculty, John Hushua, introduce the very first speaker, Victor Volovici, and so we can get everything started. John, please go ahead.
Yeah, thank you. Yeah, so first to speak today is Professor Victor Volovici, who is a cerebrovascular and skull-based neurosurgeon at the Erasmus University Medical Center, Rotterdam, and the co-director of the Center for Complex Microvascular Neurosurgery. He leads neurovascular research and serves as the president of the Netherlands Neurovascular Society, and he is a visiting professor of experimental microneurosurgery in Romania. His clinical expertise includes cerebral aneurysms, arteriovenous malformations, pediatric cerebrovascular disease, and microsurgical education. Prof is recognized for advancing evidence-based evaluation of emerging neurovascular treatments and improving neurosurgical clinical research methodology. His work supports optimum treatment selection for complex cerebrovascular conditions by balancing microneurosurgery, endovascular therapy, radiosurgery, and conservative management. One good thing about Prof is that he advocates for critical appraisals of evidence, careful patient selection, and long-term outcome as essential components of high-quality cerebrovascular care. It's my pleasure to introduce Professor Victor Volovici today to give his talk at this presentation. Thank you very much.
Thank you very much, John. Thank you very much, Mario, for this, for inviting me and for having me here, and well, let's say for even touching upon this topic. I'm going to just share my screen, and I'm glad to discuss what complex microsurgery is. Why is there a need for a center or European network of complex microsurgery? What are the strengths? What's the limitations? And what does it need to train? Of course, we all know that, you know, if we look back in history, then we see that there's a so-called microsurgical hero era, the 80s, 90s, where all these big surgeries being done, and the forefathers have laid the ground for what we do now. And what basically happened in these past years is all we did was refine the technique, but we also refined which patients actually need complex microsurgery, because not everybody needs complex microsurgery. You know, the 8mm ACOM with subarachnoid hemorrhage will always get coiling, even in Rotterdam. And even some of the more complex ones don't necessarily require surgery. But there is still a patient population which does require surgery. And this is, let's say, the patient population that I am most focused in. As you said, I'm very much an advocate of thinking. So there's no right or wrong. There's just evidence, and there's us, the practitioners, who understand our limitations and our strengths and can decide the best medical treatment for the patient, which may not be the same in Rotterdam as it is in Zurich, as it is in Helsinki, as it is in Boston, because many of the things are different in terms of what the patient expects, what the patient wants, and what we can offer. So it's powerful, it's limited, but it's also trainable. So of course we have a narrow and unforgiving set of problems which just cannot be tackled in a different way. And I'm going to be touching upon this with 5 illustrative cases. But it's also limited because these procedures and this patient population carries real morbidity and a shrinking caseload. So sometimes a hybrid answer is better than just one huge surgery just because we can do it. And it's trainable. But it's not only trainable. There's a certain necessity to keep the training alive and to refine the training. as I will touch upon at some point, if somebody can do an SDMCA bypass, that does not by any terms mean that someone can do a deep bypass like petrous carotid or P2, which is a whole different perspective, requires different training. So we cannot just sit back and think, oh, I can do bypass, and then you can do any kinds of bypass. No, there's different training necessary for different kinds of things. So where is it irreplaceable? Well, moya, of course. A complex giant aneurysm, still an ongoing debate of what to do. Arteriovenous malformations. We've seen in recent years, and just last year, a group of Raymond published a stroke trial with transvenous versus transarterial. Endovascular standalone has just too high incidence of morbidity after treatment. So the solutions for AVMs should primarily be microsurgical, which we'll touch about in a minute. And of course, steno-occlusive disease. Now, if we see what our own practice shows, you can see that despite the fact that we do a lot of microsurgery, there's still, of course, a lot of endovascular going on, which is more than microsurgery, but there's also a lot of bypass going on, which illustrates the kind of complexity that the aneurysms that we're treating nowadays require. So a lot of the complex aneurysm practice is actually bypass to a certain extent, to progressively more complicated. So I'd like to show this case, which is a 64-year-old gentleman coming in with this giant MCA aneurysm. So all you're seeing on the MRI is just one giant thrombosed aneurysm, but also with an occluded M1. Now, this was a diagnostic conundrum because at some point, the inference was, most of his symptoms come from mass effect. But when we looked at the CT perfusion, it was obvious that he also had some hypoperfusion in the right-sided MCA territory. So it wasn't just enough to close off the MCA or do a flow diverter, because he obviously still needed revascularization. So in this case, what we did is, so of course, preparing the SDA under the microscope, you can see some obvious Japanese influences in this way. Now we prepared a double flow, a double barrel bypass. We did an IC green to see the time to drain in between, so the time between the arterial and the venous phase, which we use often as a sign of what needs to be done. Then we found a good donor in an M3 artery, and then we measured, so we did an SDMCA, and we measured the flow. It was 65, which is actually exactly what the MCA territory in this case needed. So there was no need for a high flow bypass in this case. So we need to measure flow, and we need to look at tools which give us a better idea, not about the flow, because it's not about the flow, it's about the perfusion, which is something much more complex. So after we did this bypass, we of course checked the IC green, and there's the M1. You can see it all calcified at the base. We occluded it, and then we went transinsular through a limit insulae and just put the CUSA inside the aneurysm without resecting the wall, because otherwise there would be damage. And you can see the 3-month MRI. So again, also in this issue, it's quite important. We always perform MRI in these patients to see what's happening, with them. So it's not just about surgery; it's about long-term outcomes. So how are these patients doing after all we've done to them? Now, if we're looking at AVMs, surgery in the new observational studies that have been published. So the MATCH registry from Beijing, the Tatum trial, the MARS, and the MISTA. There's one signal coming out of these research, which means microsurgery should be the first option if these patients look operable at all. And we're not just talking about, because there's, in many centers, there's a discussion of, well, it's a Spezza-Martin just one feeder and just one draining vein. So, you can embolize. But even, in these kinds of cases, sometimes embolization may not be complete. So if there's a possibility to do a microsurgical resection without permanent deficit, so the kind of outcome that we consider now well, which is complete obliteration without neurological deficit, only microsurgical resection achieves this this goal consistently. So what you can see here is grade 4 left parietal AVM with an intracerebral hemorrhage. This was 1 day before Gamma Knife. This 64-year-old guy, statistician. He, understood the ins and outs, and he said, "Well, I don't trust the trials, and I don't trust the Aruba. I'm going to go for Gamma Knife." But 1 day before Gamma Knife, he comes in with a hemorrhage, and then we said, "Well, we can operate on this." So he was a bit surprised because he had been told that it's inoperable, left-sided, but especially when they have a bleed, most of the bleeds come from the deep part and part of the AVM that goes more choroidal. So the only thing he had after the bleed was a hemianopia. We said, look, this is probably going to get worse after surgery, but it's likely that it's going to improve afterwards. So even though this is a huge AVM and of course a lot of flow going through it, so first strategy was going interhemisferal and closing off the posterior circulations. So the P2 feeders that were coming out of them, big ones, we closed them off. Of course, you can do that with embolization as well. The problem is that if the nidus is very much embolized, then it becomes less soft, and especially when a nidus is so big, they have these calcified venous ectasias. Moving it along and manipulating it a little bit is going to be more difficult. So what you can see is we're dissecting. So, subarachnoid dissection AVM takes, especially with these big AVMs, maybe 2-3 hours just to expose everything and not just go directly through the cortex, but first just expose, look at the images, because the true art of AVM microsurgery is being played in that 1 millimeter plane between the nidus and the normal white matter. So if you go through the nidus like a cowboy, then it's going to bleed and it's going to rain blood. But if you go too far, then you're going to take out some of the function, which you maybe shouldn't have. So, staying on that one plane is important. You can see the venous ectasia being removed. Now you can see the bled cavity. Can see the draining vein becoming progressively more blue, and now we can disconnect both draining veins and remove so you see the last draining vein is being disconnected, and we can remove the whole nidus en bloc. And even though it's left side, it's quite a large piece. You can already see the pile vasculature relaxing as the flow has been removed. And you can see also in this case, immediate post-op MRI shows no DWI damage outside of the area where we had just operated. And he had hemianopia, which got worse, but also improved in 1 year time. And after 1 year, he had almost no hemianopia. He kept a diary of how far his field of view was. So we need to be honest about the limitations as well. So we have a flimsy evidence base, even in terms of microsurgery. I mean, yes, of course, sometimes I criticize endovascular devices, but microsurgery doesn't fare any better. So, we need to invest in good quality evidence across the board. It's not just about endovascular. And we have a caseload that's just too small to sustain skill everywhere. So you can see that the evidence we rely on in terms of all the things we consider safe and effective, even in 1,300 studies of almost 500,000 patients, only one of those 1,000 studies set a threshold of what is safe. Is 5% mortality for unruptured aneurysm safe? Is 2%? Is 10%? Is what is safe? 40% had incomplete outcome reporting, which should have been reported should one claim safe and effective. And there's, of course, a real morbidity for these patients, because especially when we deal with very complex AVMs or complex aneurysms, the chance of problematic complications is very high, sometimes as high as 30%. We need to be honest with patients and, of course, our colleagues. And there's a shrinking caseload. So there's just fewer reps to build skill. You cannot just expect. So, as we hear nowadays, are the normal PCOMs where people used to train on. They don't exist anymore. So there's no normal PCOM. Everything you get is fusiform, big and wide-necked, and all kinds of branches coming out of it. And there's a long learning curve, which is quite unforgiving. So we need to concentrate care, support, and sometimes combine approaches. So this type of AVM, this is what I consider a bit of, let's say, the edge of what can happen. This lady, 41, she has HAT, so Rendu-Osler-Weber disease, and she also has lung AVMs, AVMs in other parts of the body, and she has TIAs because of steel phenomenon from this AVM. So she's like a sixth opinion. She's seen everybody. She's had people who say, "Oh, I can take this out immediately." She's had people say, "Oh, you don't touch this." So the big issue with this AVM is, of course, the interface with the brainstem. So you can see this very diffuse nidus just at the edge of the brainstem. Well, that can be, this can be either the millimeter that's too far in the brainstem or the one that's not. You can see in these actuals, the whole cerebellar hemisphere has a lot of draining veins going out of it. And another issue is that if you want to disconnect this, you won't reach it immediately. So what I did is, in this case, a two-step approach. This is my neurotologist doing a trans-petrous pre-sigmoid approach, not translab, because her hearing was intact and the edge of the petrous bone was well enough that we could just approach through a pre-sigmoid part. You can see the sigmoid sinus being exposed as we speak. And then you can see there's the fallopian canal, a facial nerve. And this is 2 days later. So we woke the patient up, and we put in the ICU, and then now we can get onto the resection. And you can see this is the pre-sigmoid area. So I'm already disconnecting, starting to disconnect. You can see a couple of petrosal veins with a lot of shunts. So now I'm disconnecting the first part. You can see 9, 10, 11 there. So just getting this petrous part of the AVM first was very much necessary. Then I'm dissecting across the pica, and you can see some choroidal part coming out of Lushka. And those were very tough vessels, and there was so much flow on them that they just wouldn't coagulate, most of them. So you can see this was maybe 14 hours of continuous, trying to keep that edge in vessels that just won't coagulate. So stuff that looks like this, and trying not to, so resisting the urge to just take out half a hemisphere, because that's also, I wouldn't have considered it a good approach if that were necessary. Now you can see the edge with the brainstem, which needs to be kept and not go too far the peduncle in. You can see that as the surgery progresses, we keep changing bipolars because at some point they just don't do what you want. And here at the end, we can remove this big piece. She had no brainstem problems, fortunately, but this was pretty close to the edge of what microsurgery can do. This is now she's 3 months across the line, and she's doing quite well. So the best of both worlds is often the right answer. So staged AVM treatment, a flow diverters and bypass, one suite. And if you can't do it yourself, the hybrid approach, then it's really good to have a team in which you both act as one. So with your endovascular specialist, make sure that you have such a way of communicating that you can devise hybrid options. So the hybrid mindset, in a way. So this basilar trunk aneurysm in a 25-year-old was considered untreatable growing, untreatable in Rotterdam. So he went to René Chapeau in Essen. He did a beautiful stent and coil. But what happened afterwards is you can see that on the ICA, this fuzzy thing developed. So there was at first glance, they were wondering, what is this, an AVM of the vasa vasorum? There were a lot of crazy theories going on, but there was no way to get into that because this was a cross from a stent. So there's no way to get there endovascularly. So we thought about a hybrid option, which was this is the occipital. I'm dissecting the occipital from extended retrosigmoid approach. You can see 9, 10, 11, and 7, 8 with a very beautiful ICA loop. This is the subarcuate artery, is one of the only ones that can be sacrificed. Of course, the labyrinthine artery cannot be sacrificed. So you can see above 7 and 8. And you can see now why it looked as if it was like a vasa vasorum, because these are canals inside a thrombosed aneurysm. So you can see all the brainstem perforators coming out of it. You can see the end of the stent. And from the end of the stent, this huge thrombosed aneurysm was developing. And this guy had a growing aneurysm and progressively more symptoms. So what we did is, this is me exposing the V4 segment to have some proximal control just in case, then trimming the occipital, and then this anastomosis on top of 7 and 8. But so this anastomosis is at 7.5 centimeters depth. There's no, if one can do an STMCA, that doesn't mean that one can do an occipital to ICA bypass. That's a whole completely different story. You need specific special training for this type of deep bypass, because your instruments have a completely different way of reacting, and they're continuously at the 45-degree angle, so at depth, so it's not the same as you can see the bypass open and icy green. And afterwards we wanted to coil the aneurysm, but because we don't have a biplane hybrid OR, we actually had to clip it, which gave a little bit more manipulation on the 7th nerve than I would have wanted. You can see the infralp angio. You can see there's no this post-op MRI day 1, no T2 abnormalities in the brainstem or the cerebellum, but he did have a Haus-Brackmann 3, because we wanted to close off the ICA through the stent, but they just couldn't get to it, so that was a problem. He's of course recovering now. He has a Haus-Brackmann 2, but it's still not a perfect case. So training in the future, you can't just accumulate skill case by case. You have to build it and you have to measure it. And they did one of the PhDs that they did in the Netherlands was they were looking at top Olympic swimmers versus the ones that are just underneath. And what they saw is that the top swimmers don't train more than the ones who take second and third place. They actually train less. But what they do is they train the things they are worse in. So let's say you're training in deep bypass, but you progressively have bite sizes that are too big, or your vessel sense of vessel positioning in a depth is wrong, but you're pretty fluent in tying the knot. Then you have to train the things that you are not so good at, which is not so fun, because when you're training things or everything or the things you're good in, then it's more fun. But specific training for specific tasks, that's what's necessary. So we have all these doctoral things like sensors on the hand, and we have a standardized test. You can see how we're measuring people, and we're moving from looks pretty good. Everybody who's done a fellowship think, oh yeah, it looks pretty good, to numbers. We want to know, precision. We want to know amplitude of movement, and move towards a more objective assessment of what the movement and the stuff really means. So you can see that structured training actually leads to less mistakes in an anastomosis. And when you have an aneurysm like this, You can see the angle there coming out of the P1. This is also a young lady, 32. And yeah, there's really not a lot of options for this one. The only way you can treat this is if you do, for instance, flow reversal, but you need, this case tests everything, because, for instance, if you cannot do or if you cannot reach the basilar apex, you cannot close this off. And of course, again, we had the same problem with not having a biplane OR. Then they cannot close off the P1 on the right side. Also, you can see that the SCA and P1 have a lot of have a little bit of the bifurcation in common. So coiling this is quite difficult. Whereas if you can put a clip on the P1, then you can save it. We also have a good 3D angio to see that one perforated trunk is coming out of it. So we need to save that. So what we did in this case is we prepared the SDA, of course, as we always do. Then you have to be fluent in skull base, because you have to reach that area. So we did you can see we opened the fissure. Then we dissect this ICA terminus. You can see the aneurysm and the P2 coming out of it, and the PCOM with all the perforators just on the insertion point. Now I'm cutting the tent. Now you need to be able to, dissect the third nerve, dissect the fourth nerve, cut the tent, really make that space. Otherwise, you're never going to be able to make this bypass. You're going to pull on the right temporal lobe so hard that it's going to have an infarction. Then you need to, there's a P1, you can see the flow measurement. And then you need to cut the PCOM. So what I did in this case is the SDA stump actually gave 43 cc's a minute, which is exactly what the P2 needed. So what I did is I put the radio on the SDA stump. The other option was the external carotid, but that usually gives a lot more. So you can see there's the deep anastomosis on the other side of the tent. So in a radial artery P2 bypass. And then you can see the IC green. And then we also close off the other M1 aneurysm, and you can see the intraop angio. There's a clip on the P1, SCA is preserved, the perforators are preserved, and this is the radial for the whole posterior territory. And day one MRI showed no brainstem abnormalities and nothing apart from, of course, some hyperintensity in the lung, because she did well. She was home after 5 days. So we have fewer hands. We also need fewer hands, but we have a much higher bar, and we need to measure it. So measured skill, expertise, networks, and the hybrid mindset by default. There's no clipping versus coiling. That's so 20 years ago. This is the hybrid mindset. How can we come up with the solution using all the tools that we have at the highest level? So not, people who can't anchor flow diverter properly in very complex situations, but the highest possible level from both skills to make sure that we find the best possible solutions for our patients. We have a new microvascular course from the ANS, and I thank you very much for your attention.
Thank you, Victor. Wonderful presentation as always. I think lots of take-home messages for our attendees. If you may, just want to stress the importance of really this hybrid mindset. For those of us who practice or have been trained in North America, this is really, it's been the case for the past 10 years at least. And that's why whenever we are in meetings, particularly on the other side of the Atlantic, the discussion is always, how can a patient get the best of both sides, interventional and surgical, and there might be provided by the very same person. Here in Europe, we still have some issues with that, but I think we can compensate with team working. And we can compensate precisely like you say with a lot of hands-on training. So the microsurgical course that you run for the EANS is really golden from that point of view. I want to ask you, when you were a medical student, could you envisage that you would end up being professor in Rotterdam and performing these type of complex surgeries?
No, I had no idea. And when I
And based
started
on
as
that, which type of advice would you give to the current trainees?
yeah, so when I had the, well, let's say, the fortune of entering a research group who did actual transplant research, but their rats were dying because of anastomosis, so that's how I rolled into that. But it began actually with just loving the fact that I could sit for hours behind a microscope and just loving that, So if I hadn't gotten here and gotten into this, this whole position and everything that I do, I still would have loved what I do. So, it really begins with what do you enjoy doing, and so my advice for trainees is find something that you're really interested in, that you love. Don't think about, oh, how can I get into, to being professor or this or that. Just, finding something that you love. I remember that I was in a career path when I was doing a PhD, and I was still training because I loved doing it, not because I was, training on a microscope, not because I wanted to do something, but just because I enjoyed it. So enjoying what you do and really getting into research for a topic that you're passionate about, I think, are the two things which are very important. And to just not thinking about, oh, I want to become this or that or chair or whatever, but it starts with loving it.
Perfect. Yeah, I think that's the message for all the attendees of the Oxford Global Neurosurgery Initiative. Victor, thank you so very much for your time. We'll move on now with Phil Toschi from Harvard University. And Phil, are you happy to share your screen?
Yes, give me 1 second. Can you see it okay like that?
It looks wonderful, Phil. So Phil, as you can see, works Beth Israel Deaconess Medical Center, is affiliated with Harvard University. Originally trained in Switzerland, and then he moved to North America, where he spent many years working William Codwell, and now is in Boston. He's a co-director of the Brain Aneurysm Institute. And the talk that is going to present is being long awaited by the Oxford Global Neurosurgery Initiative webinars. We will have today the opportunity to listen to him. So please, Phil, go ahead, and we are so eager to listen to you. Thank you.
Thank you so much. Thank you, Mario, for the kind invitation. Thank you, Victor. It's always a pleasure to see you and hear your cases. I want to be talking about small aneurysms, which I think is one of the real big problems I feel in our treatment of aneurysms in general. I think we have a couple of big challenges in current management of aneurysms. One is, of course, as Victor already mentioned, is simply training young neurosurgeons, not only for open, but also for endovascular techniques. I feel very strongly that this is all neurosurgery, and we should be front and center in taking care of this pathology. Then how do we manage recurrences and residuals? I think there's still a lot of research to be done. How do we manage elderly patients, both in ruptured and unruptured settings? I can tell you that in our practice, it's not unusual to see patients in their late 70s with 5 millimeter MCA aneurysms, and they want to have this treated. And we have very limited data on how to go about it. But the talk today will mainly focus on how to manage small aneurysms. Big things are happening for small aneurysms, and I want to credit my partner, Dr. Ogilvy, who was really front and center in these trials and a real thought leader about small aneurysms. Just want to give you a small background about our Brain Aneurysm Center at Beth Israel. We treat about 200, 250 aneurysms a year. Even though endovascular, of course, is very strong, we still clip a good number of aneurysms. Overall, We try to make it all learning experience. We have many observers and fellows, residents from across the country, across the world who join us for these cases, not only clinical, but also in research. And then we try to treat both the OR and the angio suites as ORs. And so our neurosurgery residents, they do a 6-month neurovascular rotation, and there they do open vascular and endovascular. And you see this is Charles Mackel, who's actually now one of our fellows, but when he did a 6-month rotation, these are the kind of cases that he ended up doing. So you can get trained very quickly, very well, I feel, I think, which is the positive take-home message overall, also from Victor's talk. But why do we treat unruptured aneurysms? Of course, it's a big question. It's a big question in many different parts of the world. It's also a cultural difference in many places. Like I said, here in the US and especially in Boston, everyone wants to have their unruptured aneurysm treated because the sense is that this is a very morbid pathology that needs to be taken care of, and many patients in their 70s want to have this treated. So if you look at small aneurysms, they're actually very common. They're much more common than, of course, larger aneurysms. The majority of them are below 7 millimeters. And if you look at the literature, there's really no consensus on when to treat versus to observe. We have, of course, trial like the ISUIA and phases and so on. But I would say they lack consensus for any individual surgical cohort. Of course, the main question is always risk-benefit balance of risk of natural history versus the risk of treatment, but I want to get into that a little more. I know that, you know, examples and anecdotes are never proved, but I think they are what we deal with, right? We don't deal with surgical cohorts, we deal with individual patients, and they are our guidance and they inform our decision-making often. This is a 80-year-old patient who came to me when I was still at the University of Utah. You see a small pericallosal aneurysm measured 2 millimeter. I told her I would never treat this. I think likely you'll outlive this lesion. And she came back a few weeks later with just a fatal rupture. The aneurysm, interestingly, did not grow from when it was unruptured to when it was ruptured. So it was a rupture at the same size. And just telling you how we don't understand this pathology very well and how poor we are at making any kind of predictions about any individual risk of aneurysm rupture. And so I regret this case very much because it would have been a very easy coiling and this could have all been prevented. But of course, we lack really consensus. Here's another one of these cases. This is, you know, a small MCA aneurysm that you can treat or you can watch. We decided to microsurgical clip this, and then you see here under the microscope, and many of us who do a lot of microsurgical clippings experience this, where we feel these aneurysms may be quite benign. You end up treating them for different reasons. They may have a family history, they may insist on treatment. And then under the microscope, you see that this is actually a very malignant lesion in the sense how irregular, thin, and a bleb you have there that you can see actually the blood swirl in it. And so we're happy to treat that. But again, it tells you just how ill-equipped we are to make any individual informed decision for these patients. This was a patient, she's actually a physician in our hospital, and she presented with a rupture with this small 3 millimeter PCOM aneurysm. And she was still with it. And she said, you know, can you try to coil it? And if you can't coil it, you can just go ahead and clip it. And so you also see how difficult it is to endovascular treat these small aneurysms. You see here the microcatheter little point in the aneurysm. You have very little room for error when you have to treat these small aneurysms, because if you go a little more distal, you'll rupture the aneurysm. And if you're too proximal, you'll have coiling the parent vessel. And so we balloon coiled this But you see what happened with the balloon inflated, the coil mass looks good, and with the balloon deflated, the coil mass actually herniated through the aneurysm neck into the parent vessel. And so we pulled out the coils and ended up clipping it, and that went well. But she actually asked me in follow-up, she recovered very well, luckily. She said, would you have treated me if I had presented before rupture? And I said, I really don't think I would have. You know, this looked like a very benign 3 millimeter small aneurysm that, even though the patient's in her 30s, I think in many places in the world would have just been watched. So really hard to make any kind of decision. This is another small aneurysm with which I want to start our smalls discussion. This is a lady in her 50s. She's actually a well-known author who has a very strong family history of brain aneurysms. She's one of these people. She has a brother who had a ruptured aneurysm, a father who had a ruptured aneurysm, a cousin who had a ruptured aneurysm. She's a smoker, and then she has this MCA aneurysm. And she, of course, insists on having it treated. And again, it's one of these cases where intraoperatively we see that this is really a tiny, dangerous bleb that we ended up clipping. But I think we have good reason to treat these kind of aneurysms, and that's what I want to get into in the next part of my talk. If you look in the literature, if you ask physicians, do you treat small aneurysms, meaning more than like 2 to 4 millimeters, most everyone will tell you they don't treat these aneurysms. But we actually know from published studies that that's not really the case, and that it may be a little bit like voting for Trump. Most everyone says they don't vote for Trump, but we know that that can't be the case either. And so if you ask physicians, 90% of people will say, 90% of physicians will say they wouldn't treat it, they would just watch it. And here you see how often they would watch it, they would elapse it. And the problem that we have, of course, is that we have such poor longitudinal data that informs our decision-making. And to make things even worse is that we detect more and more unruptured aneurysms. You see with CTA and MRA, every year, basically, we see more and more unruptured aneurysms, but our knowledge on how to treat these, especially small unruptured aneurysms, hasn't grown as exponentially as the detection rate of new unruptured aneurysms. And so we come up with these scores. This is the FACES score that tries to put together these aspects of population hypertension, age, size, early subarachnoid hemorrhage, and site of aneurysm into a point system and then make decision. And we looked at this very carefully. If you look at one of the most important aspects is size of aneurysm. Basically, it only makes a distinction between smaller than 7 millimeter and larger than 7 millimeter. And smaller than 7 millimeters, they're all treated the same and they all get 0 points. But we know from this is the Japanese study that was also a natural history study, the UCAS study, that actually there's a very big difference between an aneurysm that's 3 millimeter and an aneurysm that's 5 millimeter. And so probably the FACES is not really accurate in predicting rupture rate overall. And there's a big difference between a 3 millimeter, 4 millimeter, 5 and 6 millimeter aneurysm before we get to 7 and above, which again, you see has a much higher probability of rupture. This is based on the Japanese UCAS study. And then to further complicate things, and this is a very interesting study out of Johns Hopkins University, where they looked at ruptured aneurysm vessels location over time, and you see that from 1991 to 2016, the distribution of aneurysm rupture actually doesn't change, the location doesn't change, but the big change is that more and more small aneurysm end up rupturing. So in 1991, it's only a third of ruptured aneurysms are smaller than 5 millimeter, versus in 2016, this is 50% now. So we have these two worlds that don't speak with each other, where we think that these small aneurysms are very benign, but then if you look at ruptured aneurysms, the majority of them are actually now smaller than 7 millimeters, and for sure smaller than 5 millimeters. And if you look in the literature review, if you look at ruptured aneurysm smaller than 5 millimeters, the distribution is actually quite wide, but it seems to be increasing over time. In the 70s and 80s, it was between 4 and 30%, whereas now we really are in the 50s with these small aneurysm causing subarachnoid hemorrhage. And the other thing is that we start, maybe as a result of some of these insights, we looked at unruptured aneurysms being treated, and we found 31,000 unruptured aneurysms in the literature. And what we found was that the overall size of aneurysms being treated that are unruptured is actually decreasing very significantly over time, with a 0.71 millimeter decrease in average size every 5 years since 1987. So when you ask the physicians if they treat small aneurysm, they tell you no. We know that that can't be true. And we looked here at the aneurysm size, which is the y-axis, and the x-axis is time. And you see how the aneurysms get smaller and smaller over time, and have sort of surpassed this threshold of 7 millimeter, smaller than 7 millimeter in 2012. And this is interestingly true not only for endovascular cases. You may think that endovascular cases are they're more aggressive because it's easier to treat smaller aneurysms. That's also true for the surgical cohort, where we end up treating smaller and smaller aneurysms. And it's a phenomenon that we see all across the world. The strongest, of course, is of this phenomenon is seen in the USA, but also in Europe, to a lesser degree in East Asia. But we have some indications that this is changing too. And to further complicate matters is that a lot of these unruptured aneurysms are being detected more and more in elderly patients. And so that further conflicts our decision-making in this unruptured patient population. So we wanted to come up with a sort of a score that helps us guide. And what we did is we looked at basically all the published data that analyzed growth and rupture risk in the literature, and we found 14,000 aneurysms smaller than 7 millimeter, and we analyzed them according to all the data that was available in the literature. And we found a couple of things. One is that there's a big difference in significant risk of growth and rupture between aneurysms that are smaller than 4 and larger than 4 millimeter. And so we incorporated this aspect, and you see that's a big difference when you compare it to phases. And then we looked at our own series of unruptured aneurysm, both treated and untreated, and we did a retrospective review, and we categorized them by these natural history risk factors, and we examined treatment outcome by these risk factors. So a very large aneurysm number. We're a very large referral center, of course, for these cases, with over 2,000 aneurysms that were evaluated in clinic. About half of them were treated, half of them were managed either surgically or endovascularly. And so we analyzed them. We came up with our own scoring system, and then we asked our friends from Thomas Jefferson University to validate our insights. And so we looked at our total unruptured aneurysm cases smaller and larger than 7 millimeters. And we looked at how we treated them, and then we looked at our complication rate, and then we placed the filter of our treatment decision evaluation, and that was based on our study of the literature. And we came up with these 7 most important risk factors that include both patient-specific factors such as age, family history, and smoking history, but also aneurysm-specific factors like size, multiplicity, irregularity, and location, and came up with what we call the small score, a score for aneurysms that are smaller than 7 millimeter, and came up with these aspects: size, smaller than 4 or larger than 4 millimeter, multiplicity, anatomic location, lineage, lifetime risk, smoking history, and shape. And then use that filter for our own cases to see how we treat or not treat our own patient based on our very own small scale, and then looked not only at treatment or not treatment, but then looked at our own complication rate based on the small scale score. And what we found was that probably above 2 is where you can warrant or indicate treatment. So small scale of 3 to 7 is probably where you start beating natural history without making matters worse by your own complication based on our own numbers of treated aneurysm growth, rupture rate, and complication rate. And so you see here these higher scores tracked with the decision to treat, and they translated well into the decision to treat aneurysm versus to conservatively manage these aneurysms. And you see the complication risk stayed low and flat across the scores, which was another good indication for us that with a score scale, with a small scale of 3 or higher, that we're doing more good than bad in this patient population. And so to go back to this case that I introduced initially, where we're really on the fence on what to do, you see if we place her now on the small scale, for size, she gets a 0, but she has multiplicity of aneurysm. She also has a small ACOM. She gets 1 point. She gets 1 point for family history. She gets 1 point for smoking history. And she gets 1 point for this little bleb. So now you see that what initially was a small MCA aneurysm gets a small score point of 4, which is actually very reasonable according to our complication analysis to warrant and indicate treatment. And so we find this to be a very intuitive sort of bedside screening tool that can guide us in our decision-making. It's a practical decision aid. It's risk matched based on our complication rate. We looked, of course, at our complication rate and at our occlusion rate, which was overall 93%. It was reproducible. We had our friends from Thomas Jefferson look at it retrospectively. We need now prospective validation, which is really the next step. There are still many uncovered questions that we have, such as, what happens if you have multiple aneurysms? Let's say the risk is 1%. Does that just multiply for each aneurysm, or what is the risk? Is it different for all aneurysms together, or I think they're still really not settled, and we still have much more work to do in the future. And so to wrap this up, final thoughts, I think small aneurysms rupture more, are diagnosed more, and are treated more. I think that's why our small scale is so important. We need not only patient-specific factors, but also lesion-specific factors to make and guide our decision. And then, of course, we need to be well-versed, and I think that's where Victor and I look really eye to eye. We need to be well-versed and well-trained to take care of these patients and beat natural history and do the right thing for these patients. And so I want to thank you. I want to acknowledge Dr. Ogilvie, who's a real thought leader on these issues, and of course our trainees and fellows and research fellows who are also in the room here and listening. Thank them very much for all their help and support.
Wonderful. Thank you, Phil. It was a great presentation. I think we have learned a lot from the small score. I fully agree that there is a wind of change in neurosurgery, and most likely what my generation, your generation was taught during training is being outdated by the change in our clinical and surgical practice. I was last week as a visiting professor in Incheon, Republic of Korea, and I had the opportunity to see the beautiful things that are done under the guidance of Professor D.K. Yoon, is the head of the neurovascular center there. I was there to see more about spine and neurotrauma. Those are my area of expertise. But I fully believe that even as a general neurosurgeon, we need to have a good understanding of what others are doing. And certainly vascular neurosurgery is a big proportion of the neurosurgical pathologies and occupies an important part in the spectrum of the neurosurgical curriculum. And that's why I was so keen on having you and Victor presenting together for the Oxford Global Neurosurgery Initiative. The question that I would have for you is on small aneurysm. I really see the point of the complexity, particularly with the coiling, because they are more prone to intra-procedural rupture. But equally, the location of the small aneurysm might sometimes make it very, very challenging to clip them. Do you think that in the future we will see more and more other endovascular options like stenting, diverter, depending on the size? Now there are those flow disruptors that are the big deal in management of vascular malformations. What are your thoughts on the years ahead?
It's a good question, Mario. Thank you for this question. We had recently a journal club with our colleagues from Tiantan Hospital, which is, of course, the largest neurovascular center in the world. It's in Beijing, China. And they felt very strongly that in the future, small aneurysms are going to be clipped because the endovascular technique is just not as safe as a microsurgical clipping. I think microsurgery has also changed a lot. You were speaking about Korea, where a lot of it is done through an eyebrow incision, really minimally invasive. Patients recover very quickly. If you look at the overall occlusion rate and safety profile, especially for small aneurysms, that may be, the very small and the very large aneurysm may really be one of the important bastions of microsurgery going forward. I really don't see a lot of new endovascular devices changing that balance.
Okay, we are about to close the session for today. I don't think we will have time for the third speaker. I can see in the among the attendees my good friend Victor Hugo Perez. Would you like to make any comment from your experience?
Well, I have experience in tumors, not in vascular surgery, and also in neuroanatomy. I am doing research in vascular anatomy.
We all know about that, Victor. Yes.
Yeah, well, lectures are impressive, really impressive. I like a lot this kind of surgery, but I don't do it.
Any other comments from the attendees?
You hear from the students in that little room there? The residents, they're all packed in the room there. I guess not. Guess not.
Hi there. Yes, thank you so much for the wonderful
Welcome,
talks.
you guys.
Thank you. Thank you so much for having us. Any questions?
Very good.
Okay, thank you. Thank you
Okay,
again.
thank you. Thank you for coming. Back to
Luigi,
you, Mario.
Luigi, any comments from you? Because we didn't have the time to go ahead with your lecture, but you are on mute, Luigi. So Professor Berra, you might not know, but he was one of the awardees from the Italian Neurosurgical Societies. I am particularly fond of him because he was my senior training when I started neurosurgical residency in Verona. And he has obviously a wonderful experience. He trained extensively, not only in Europe, but also in North America. So Luigi, do you have any further comments you would like to add, please?
I want to compliment with the two speakers because they did wonderful lectures, and we all grew up with the possibility that vascular neurosurgery would disappear. Endovascular is going farther in the future. There will be no room for surgeons, and I'm happy to see that this is not happening. Okay, so we are still important in the management of vascular pathology.
Yes, I totally agree, and that's why I previously asked Phil what were his forecasts for the future. I really think that neurosurgery still remains ahead of the game, and I think the presentation from Phil really underscore how big data analysis helps creating new scoring system and appreciating that there are many unmet needs in our clinical practice, and this starts from from all of us. As I say, there should be an appetite for learning, constantly understanding what the best are doing, trying to steal their ideas, replicate in our daily practice. And I think that's what is really the value of organizing this type of webinars. I think Luigi, I'm truly sorry we didn't have time to go ahead with your presentation, but I will be delighted to give you space in another Oxford Global Neurosurgery Initiative webinar.
Thank you, Mario. Thank you to all the attendees.
Perfect. So John, I go back to you so that you can wrap up today. And thanks as always for having us in neurosurgical.tv.
Yeah, Mario, another quality presentation. Thank you very much, and we look forward to the next one.
Thank you. Thank you so much.